Hello, welcome everyone to our Canadian Diabetes Association's National Fall Webinar Series. My name is Farah Ismail and I'm a Program Manager for the Canadian Diabetes Association, and I will be your host this evening. We are delighted that you're able to join us today for a webinar on diabetes distress. Now, to start us off, I would like to draw your attention to the right top-hand section of your screen, and that's our survey there. So in order to better serve your needs, we kindly ask that you provide opportunity to ask questions. So we ask that you type your questions into the question and answer box, and that's located at the bottom right of your screen. And our presenter today, Dr. Michael Valles, will be happy to answer the questions at the end of the presentation. You'll notice too that throughout the presentation we will be displaying a few polling questions. We would absolutely love it if you'd participate. We just want to gauge, what are the feedback from audience members and, how they respond, and we just want to let you know that your responses will be completely anonymous. It's also important to note that you're able to customize your screens, so you can expand them and collapse them as you see fit, simply by dragging down the bottom right-hand corner of your screen. So today our presentation will go about 40 to 45 minutes in length, which will leave us a good 10 to 15 minutes in length for questions. I just wanted to let you folks know that we will be recording this presentation and we will be posting it on our CDA website at a later date. So now I'd like to welcome our speaker, Dr. Michael Valles, and thank him for joining us today. But before turning it over to Dr. Valles, I'd like to give you a bit of a brief introduction. Dr. Valles is a registered health psychologist practicing at Capital Health, Halifax, and cross-appointed at Dalhousie University as an associate professor in family medicine and psychiatry and adjunct professor in psychology and health and human performance. Dr. Valles obtained his PhD and MA from the University of Western Ontario. He did his BSc from Dalhousie University, and Dr. Valles' main area of expertise is adult health psychology, and that's with an emphasis on diabetes, obesity, cardiovascular risk, and gastroenterology. Dr. Valles has developed the Behavior Change Institute, a training program for lifestyle counseling for physicians, nurses, dietitians, and other healthcare providers. So to learn a little bit more about Dr. Michael Valles, please look to the left of your screen and you'll be able to expand that information to read a little bit more about him. So without further ado, I'd like to present to you Dr. Valles.
Thank you very much, Farah. It's a pleasure for me to present this session to you. The title of the session is Diabetes Distress, and you can see from the slide that I've subtitled it, It's About Time. And I hope that you will agree as we go through this presentation that it's about time we really put the psychological aspects of living with and managing diabetes further high on our priority lists. I'm a health psychologist, and my interest is in understanding how people living with diabetes can better manage the disease in the context of their life. One thing I'd like you to understand in this presentation is that as a health psychologist, it's important that the message that I get out is consistent between individuals living with diabetes, family members of individuals with diabetes, and as well as healthcare providers who are involved in providing services to individuals with diabetes. So I do presentations that flow between all of those groups. So everything I talk about today, if you're an individual living with diabetes, then I'd like you to know that I make exactly the same points in exactly the same way to healthcare providers. If you're a healthcare provider, you need to know that I do the same presentations for individuals. And the purpose of that, and the reason that I'm making it a point at this time, is because I think it's important to know that the management of diabetes is a collaboration. Doctors are not in charge. And it's really the collaboration between the individual and the healthcare provider and the family and community that really needs to be the emphasis on living well with diabetes. So with that as sort of an introduction, what I need to do first, and this is a standard thing, if you're an individual with diabetes or a family member, this is one of the things that's important from a credibility perspective in a public presentation, which is, we call them disclosures, which is if we're involved in any way with private industry, then we declare our relationship with industry. And so I am the Canadian lead on an international study called Diabetes Attitudes, Wishes, and Needs. And I'm going to present some results of that study in this presentation, and that was funded by a pharma company as well. I do similar work in irritable bowel disorder, which is IBD, and I sit on an advisory board for obesity for Novo Nordisk, as well as I receive speaking fees that are funded by some pharma companies as listed here. Now, the objectives of this session is to help you, the audience, become familiar with a perspective on how we begin to incorporate psychological issues into the diabetes work that we do, whether we're a healthcare provider or an individual. And that's actually quite important, because the typical model that people follow right now, we call it the psychopathology model. And that is, if an individual living with diabetes were to start to talk about feeling distress, their healthcare provider might start to use language like, oh, maybe you're depressed, and maybe we should think about medication or send you to a mental health service. And I'm not suggesting that that is inappropriate, but I am suggesting that there are many other stops on the way, and that it may not be that any distress that an individual with diabetes presents is a sign of a mental health disorder. It may be that the distress is a sign of what it's like to live with diabetes. And so this will help us to help you see the concept of diabetes distress. What does that mean, and how would you recognize it? So that if you're a healthcare provider, then how might you question your patients to uncover distress? If you're an individual living with diabetes, what would you look for or recognize? And then I'll talk about some ways that we can screen and briefly manage diabetes distress. The context of this would be within what we call scope of practice. So as a health psychologist, when I work with my medical colleagues, they tell me that they have trouble talking about psychological issues because it's not their expertise. They didn't go to psychiatry residencies. They went to endocrinology, or they went to nursing school, or they went to family medicine programs. And so one of the things that we need to really appreciate is that you don't have to be that extreme expert in order to be supportive of managing diabetes distress. As a matter of fact, if the distress associated with living with diabetes is actually because of diabetes, then in fact I would say it would be the diabetes healthcare provider who probably is the best person to manage that, perhaps with the support of mental health people. And so when we talk about scope of practice, that helps healthcare providers realize that, okay, that's within their scope. And so one of the things that I try to do in my work is help my colleagues begin to incorporate these strategies into their practice, and using this sort of perspective, awareness. So one of the things that I would like to make clear today is that we need to be aware not only of the risk of depression in people living with diabetes or any other chronic disease, but we also have to be aware that diabetes distress might actually be more relevant to the average person that we see in our practice. And so awareness then leads to competency. And so how do we start to develop a language and measure and understand what we are working on? So what are the strategies? And then how confident am I in implementing those strategies? And then as we get more and more confident, then we can start to play around with them. So this is a pathway of learning that really we would all orient to. And so just if you reflect on the behavior of using text messages, most of us at this webinar would know that there was a time when we weren't even aware that people were doing that. And then we became aware of it. We didn't really think much of it. Most of us who are more have more years behind us than less. We didn't think much about it. And then we started to do it, and then we got confident, and now maybe we're using apps that we never would have considered. And so we do this, though, in a way in which we try to help our providers get the support they need in order to maintain their competencies. This next slide is really one that would help you to understand what can you expect from a healthcare provider in diabetes, or if you are a healthcare provider, you know, as a psychologist in diabetes, this is what I would say. This is the shared task. So when a person working in diabetes, a nurse, a dietitian, a physician, says, well, but Michael, that's your job. You're the psychologist, so you're the one that should be taking care of the psychological issues. I would say, well, yes, I am a psychologist, and I do address psychological issues, but there is shared space that we all share. So what can you expect from your healthcare provider? And those of you living with diabetes, I want to make the point clear. You may not be getting this right now, but part of what we're doing with CDA is we're also trying to pave the way for the future. So we're trying to improve the lives of individuals living with diabetes. So you have my permission to engage your healthcare provider in these discussions. So you can tell them that I said that all healthcare providers working in diabetes really need to understand the whole person. You do not show up as a pancreas. You do not show up just as an individual capsule containing insulin resistance. You show up as a whole person, and you need a safe place in which you can really be present with what it means to have diabetes for you. And that means adjusting to illness. And think about diabetes. There's an expression that fits diabetes, and that expression is keep your friends close and your enemies closer. And many people living with diabetes kind of think, well, that's kind of like what diabetes is like. I don't really want to have this disease. I don't like this disease, but I really need to bring it into my life. I really need to keep it close. Adaptation to self-management. There's a lot of work that you're given. And then support to integrate that into your world so that when you leave the diabetes center, that's when you begin your journey of living with diabetes. Healthcare providers sometimes think, well, my job's done. I've done my education. I've given my support. But in fact, what's really important is what the individual with diabetes experiences when they get into their world. And in particular, there's a couple of issues, and I'm not going to talk about them tonight, but I do want to put them on the agenda because there's going to be more to come on these issues. And these are really important issues in diabetes management. In fact, they are, to some extent, play a very large role in the barriers that individuals experience to improving diabetes control. So if you live with type 2 diabetes and you've been on oral medications for a long time and you find that your diabetes control is starting to slip, then don't be surprised if your healthcare provider says, what about insulin? And what we discover is a lot of people with type 2 diabetes who are managing on oral meds, when their provider says, what about insulin? The patient says, please no, give me some time, I'll get myself back in shape. In other words, there's a psychological resistance to insulin. And that often means that people living with diabetes delay the onset of using insulin. And the research evidence suggests that the longer you delay, the more challenging it can be to manage your diabetes. And the second issue that is a barrier to improving diabetes control is fear of hypoglycemia. That is, that if you increase the insulin dose, if you're on oral medications that could bring you low, the tighter your control, the more likely you'll go low. So these are really important issues, and as a psychologist, again, where I'm going with my work. So here I am talking away. Let's sort of shift it a little bit, and now I want to go to the polling questions. And so this question, and you will be able to click these boxes, and you'll see that there are 7 numbers to click. And I want you to pick a number that corresponds to the question, where 1 means not important at all, and 7 would mean it couldn't be more important. So just the question I'd like to ask you is, to what extent do you think psychological issues are important in the management of diabetes? So I'll give you maybe 10 seconds to click one of those radio buttons between 1 and 7. And then I think you hit submit if you're on that screen. Okay, so now I'm going to advance it, and we should see the results. And here you can see very clearly that over 75, maybe over 80% of people are saying it's a 6 or a 7 on a 1 to 7 scale of importance. Now that's a pretty significant finding from a statistical point of view. Of all the people on this webinar, what this is telling us is this is a big deal. And so we need to be mindful of this. Here's a second question I'd like you to consider, and I just want you to answer yes or no. Do you believe, and this is for healthcare providers, really, so think about this from the perspective of what you think the healthcare, so if you are a healthcare provider, it's you. If you're an individual with diabetes, it would be to what extent do you think your provider would need to understand and manage the emotional issues that patients face in diabetes care. So I'll give it 5 to 10 seconds and then show the results. All right, I'll advance the slide now. And 96.6% say yes. So this is important, and I want to use this exercise, and I've incorporated it into this talk, and the reason is I'm so confident of the results. And so now I'd like to share with you results that are a bit more scientific. And so I had a grant recently from the Public Health Agency in Nova Scotia to look at this issue. And when we surveyed healthcare providers, so there are 39 diabetes education centers in Nova Scotia, and we had participation from 38 diabetes centers. And we asked the healthcare providers those questions. And when we asked the question, to what extent do you think diabetes-specific and general psychological issues are important? And then when we gave them that, they scored 6.8 out of 7 on average. We also asked them the question in providing services, to what extent do you really encounter these problems? And we hear that they show up almost every day. So the evidence is suggesting from this survey of Nova Scotia that's very consistent with your opinions. So not only are we all in this particular audience oriented in the way of addressing psychological issues, it appears as though other parts of Canada are as well. And now let me show you something from the even larger. So this is a study that we just completed, and these are the countries that participated, and this is the DAWN study that I'm the Canadian lead on this study. And we actually have a total sample when we used this, of almost 17,000 participants. And so this was 9,000 people living with diabetes, almost 5,000 healthcare providers, and over 2,000 family members. So we asked them their opinions, and what we discovered is that when we asked this group of healthcare providers, my success is largely dependent on my ability to understand emotional issues. And then we reported on this 1 to 6 scale the percentage of people that gave a very high score. And here you'll see that in particular nurses, dietitians, and diabetes specialists are very strongly in agreement with this statement. Again, you can see that this is a big deal. And the challenge, though, is twofold. When we look at how confident, how competent, how well-trained healthcare providers are, here's what we get. And you can see those light teal bars indicate that not very many healthcare providers have been trained, even though they want the training. And so this is part of what tonight is about. It's about putting these issues on the table and trying to close this gap. And why is this important? Well, I'll show you this slide because this is a very important slide that I know it's data-based, and so I don't want to make that too big of a deal, but I do want to carry you through this slide a little carefully. And on the bottom of the slide, you may not be able to read it, but these are items from a very well-developed measure. And this measure is called the Patient Assessment of Chronic Illness Care. And this scale measures patient-centeredness, the degree to which people are well taken care of. So remember I said that one of the principles here is that we need to look at the person as a whole person and understand them. And so the items on the bottom of this scale are things like, I was asked how diabetes affect my life. I was asked about problems with medications or other forms of treatment. I was encouraged to set goals. I was helped to set goals. I was helped to make plans to deal with barriers. And so what you see here are two lines. And the upper line is 4,785 healthcare providers who actually think they're doing a good job. So this is the percentage of people who say they do these things most of the time or always. And so you're getting numbers like 73, 76, 72, 67. But look at the bottom number, almost 9,000 people living with diabetes. These are the patients, the individuals with diabetes, are not experiencing this. So you see, this is an important slide from my perspective, because what this slide tells us is that there is a gap between what we think we're doing and how citizens think we're doing. And so this is something that we want to put a lot of emphasis on, because where we will go and where will we move forward is to close that gap. And next, what I'm going to do is play a little video of one of our patients in our clinic, one of my patients that I work with, and she was very kind enough to help us understand what it's like to live with diabetes, and just mindful of what happens if you ignore the psychological issues and just focus only on the medical side of things. So I'm going to play this slide. I think it's just a little bit over a minute.
To what extent do you feel judged by the healthcare system?
That's a huge struggle for me. As soon as I know I have an appointment coming up with my endocrinologist, my nurse educator, my dietitian, I get stressed, I get nervous. I feel like I'm in high school all over again and I haven't studied for a test or a big exam, and I feel I'm going to come in there, I don't have my homework done, and I'm going to be reprimanded for it.
And what effect does that have on you in terms of your behavior and your emotions?
Up until 2 years ago, I canceled appointment after appointment after appointment because I didn't want to show up and I didn't want to be embarrassed and I didn't want to feel judged. And now it's adds to my stress level. 2 weeks before my appointment, when I know I'm supposed to have this, I make an attempt and I fail, and I make another attempt and I fail, and I make another attempt and I fail, and then I throw my hands up and give up, and I'm too embarrassed to face up to my healthcare provider.
So quite an interesting perspective. And when we look at the lived experience from a psychological perspective, we're uncovering the fact that this is not uncommon. And so the question becomes now, how do we correct that? How do we get started on this path that begins to bring in the psychological experience? And in doing so, I want you to become aware that what we need to do is step back. That the traditional approach to looking at psychological experience has been to think about it in the terms of the mental health disorders, what we call psychopathology. And that's why when a patient says to a doctor, I've been feeling kind of down or worried, the doctor says, maybe you're depressed, maybe we need to put you on medication, or maybe we need to send you to mental health. They're jumping to a conclusion that you have a diagnosis of depression. You may, but you may not. And so the context really is that there's a continuum, as you see in this line, and it goes from little up to a lot, and that's just distress. And at some arbitrary point, and that point is there would be the person would spill over into a level of distress that would require or would appropriately be labeled with a psychiatric diagnosis. And by the way, that functional line that you cross is based on distress and interference with your life. And the important point here is that we don't have to just use the language of diagnosis. As a matter of fact, what we're discovering is that that diagnostic label may not be as helpful as a more general label called distress. And let me explain that to you. I'm sorry, I'll just, this little box that came up, just to put in mind that the likelihood of an average person in the general Canadian population having symptoms, and notice what I'm saying, symptoms of depression is 6%. And those living with diabetes or any other chronic disease, it's about twice that, about 12%. And so the important point for me to help you understand is that as opposed to just seeing a symptom, counting a symptom, making a diagnosis, this perspective is something that I think we need to become more comfortable with, both healthcare providers and individuals living with diabetes. And that is to start with, do I have a problem? What we clinicians would call screening for whether the person is actually a case. You know, is this a person who needs help? And what we would recommend is rather than jumping to psychopathology, if you have an experience, then you must be having a problem. But to first put it in the context of what we call the quality of life model. And so how would you measure a person's quality of life, their overall well-being? Well, you would assess two things. How unhappy are you? And then you'd follow that with the question, how happy are you? So quality of life is a balance between elements of distress and elements of well-being. What pulls you down, what buoys you up. So we would start by asking those questions. And so your healthcare provider doesn't have to be a psychiatrist, but they can start to inquire about how unhappy you are and how much well-being you have. But you can see you don't stop there. And the value of this model, in my opinion, is that it then allows us to unpack both of those issues. So distress, what we need to understand is that distress related to your diabetes? And what I would want to emphasize is that if a person living with diabetes is in distress, and it's because of their diabetes, that treatment needs to happen inside of the diabetes services, because it is the diabetes that's distressing you. And to some extent, the diabetes healthcare providers will play a very important role. But the distress that you experience might be related to just problems of living, financial problems, relationship problems, economic, number of different what we call problems of living, food security, et cetera, et cetera. And those issues, we need to think about, well, where do we help people to get support to manage those issues? And then the third area is that maybe that distress does reflect psychopathology, and a referral to mental health services or antidepressant medications is appropriate. So this model allows for us to do that, but it's more explanatory. That is, we get away from just counting symptoms and labeling people with a diagnosis, and we get much closer to understanding what's driving that distress. It's also very important that we put on the table sources of well-being, what we call resiliency, that sort of bounce backness, and how many of us have been exposed to the following message through our life. When you get knocked down, you dust yourself off and you pick yourself up and you keep going. That is resiliency. And positivism. How many of us have been exposed to things in which it'll be a brighter day tomorrow. It's always darkest before the dawn. These are statements that reflect our natural communication, in which what we're trying to do really is add a positive spin. So that's a very healthy psychological tendency. And by being aware of that, we can capitalize on that to help people with diabetes bring their own strengths and their own resources. One of the things I'm very clear to teach my students is that we may be training you to have expertise, but you always have to accept and respect the expertise of the individual living with diabetes. This slide is just to show you that there are ways of assessing distress. And this is a symptom-based measure. This one is called the WHO, the World Health Organization Well-Being Index. And it's simply 5 questions. That's why it's called the WHO 5. And it helps identify likely depression. And so this is a scale that can be pretty quickly used. And when we look at the DAWN study, and here you see the global data, so the whole sample, and the Canadians, and that you can see that similar to what I had said before, you get somewhere in the range around 10, 12%. So globally, you're getting on average around 14%. In Canada, you're getting on average around 11, 12%. And people know that Canada is a happy place, right? I mean, we just know that. So there's not a big surprise that there's a slightly lower depression rate in Canada than globally, and that's because we're fortunate to live in a country like we live in. Now, this is, again, finding that confirms what we know. But notice that, even 14% still means that 86% aren't depressed. And so now I'll compare that to the measure that we used on diabetes distress and look at these data. Globally, it's around 40-some% of people living with diabetes who report significant distress over their diabetes. Further, when we asked people around the negative impact on multiple aspects of their life, so this is the percentage of people living with either type 1 or type 2 diabetes who report that there is some aspect of their life, and you can see on the right of that slide, that could be physical, emotional, financial, leisure, work, relationships, that are negatively impacted by diabetes. So again, it is not the minority, it is in fact, common. And so this takes this concept of the emotional burden of diabetes, and I hope takes it out of the corners where we think, oh yeah, only a few people who maybe aren't coping well get depressed. And it brings it into the mainstream where we could expect every second person or more who walks into a diabetes center to have issues worth addressing. And so the point of this talk really is to address this issue called diabetes-specific distress. And we have a measure of this, and that's what I'm going to end up with. I'm going to talk a lot about how we understand diabetes distress so that you can begin to either screen for it in yourself if you're living with diabetes, or in a family member if you're here as a family member, or if you're a healthcare provider. And this measure, there's 4 aspects. And this is, again, remember what I said earlier about diagnosing psychopathology. That's a symptom-based measure. So have you had this symptom, this symptom, this symptom? If you look at the scale, these areas that we're talking about aren't so much symptom-based, but they tell you what's causing the distress. So is it the emotional burden of living with diabetes? Is it the distress over all of the tasks that a person is facing with when they have diabetes? Is it related to, and here you see the original scale was physician-related distress, but we now consider this to be provider-related distress. So we're not going to pick on doctors here. Nurses, psychologists, social workers, dietitians, we equally can be a source of distress for our patients. And then interpersonal distress. So you saw Joanne earlier who talked about feeling judged. And now I'm going to show you another clip from the interview that Joanne did for us, in which she talks about how diabetes distress shows up in her life.
When we think of diabetes distress, we tend to categorize it in terms of 4 different aspects, and I'm curious as to what your experience would be in regard to these. 2 of them would be about you as a person living with diabetes, and those 2 would be the emotional burden of having diabetes and what that would mean to you, and the burden associated with all of the self-care activities. Can you talk about those aspects of diabetes?
I think the biggest thing for me about diabetes is I'm not a rule follower. I've never made a list in my life. I'm sort of fly by the seat of my pants. I hate to make plans for anything. I like to just get up and go. And diabetes doesn't allow that in the situation I'm in right now, carrying my blood sugar monitor, carrying my insulin, carrying my needle tips, and taking all of that with me. And I think that's my biggest resent of having diabetes, that it ties me down and that it makes my life like I don't want to have to carry a purse everywhere I go. I don't want to have to bring my things with me. I don't want to have to, pull out my needle in front of everybody, my test kit, any of that, because it becomes, it becomes almost a novelty for everybody else, and they want you, oh, check my blood sugar, and people don't have a good sense of what a burden it is to just remember those things. And as soon as you're forced to, then you feel guilty when you don't.
This raises an important issue, the support that you get from family and friends around the diabetes, and the support that you get from healthcare providers around managing diabetes. How do you experience those?
I think you need to look at them as two completely separate support systems. I think family and friends obviously are not educated enough about the disease, and why would they be, to have a good understanding of it. You know, generally people think diabetics are, you know, overweight, they have diabetes because they ate too much sugar, you know, or they just completely don't want to deal with it at all, and, you know, are constantly questioning whether you should be eating that, you know, can you have this, can you have that, or they completely forget about it because it's not a visible disease. It's very easy to not to forget that you have it, or to forget that your friend has it. I think healthcare providers who understand the disease, you know, who have an acute understanding of diabetes and the ramifications of not taking care of yourself, you know, the long-term effects of it. I think that they're very acutely aware of those things, but they're not interested in the psychological side of it, and they're not willing to believe that somebody has psychological issues surrounding diabetes. I think they look at it as their patients are lazy, or they don't care enough.
So this is Joanne's experience. Some of you may have similar experiences. Some of you may disagree with this experience. But I show this because I think it's really important for us to become sensitive to the fact that this can happen. And in particular, if there's anything that we can do about this that can help us to avoid this. On this slide, I just wanted to show you that this is the Canadian Journal of Diabetes, and this is the publication of what we call clinical practice guidelines. So this is the most recent version of the clinical practice guidelines published in 2013. And I was part of a small group who wrote the chapter on diabetes and mental health. And I'm just trying to show you here that within this chapter, we do address this issue of the depression as a psychiatric disorder, a symptom-based count, or diabetes distress. So healthcare providers, if you're not aware of this, this can be a guide to you. Individuals with diabetes, this is something that you can also access and refer to, and feel quite entitled to bring these guidelines into your physician, into your dietitian, and say, look, can we talk about this? Here I see it, here it is as a guideline, how can we work together? And you're probably familiar that the Canadian Diabetes Association recently created the Charter of Rights and Responsibilities for Individuals with Diabetes. And I think that's a really awesome document, because I think what it will do is it will really bring to bear what are the important issues that need to come onto the table. And so one of the things I would hope from this talk, those of you living with diabetes, is that you might feel a little bit more supported in sort of identifying your particular need for support. All right, so I'll move into the latter part of this presentation so we have time for questions. And so I'm talking a lot about diabetes distress, but notice that what I want to do now is I just want to provide a way of looking at diabetes distress as a dialogue tool. In other words, how do we use it to have a conversation? And so what this involves, and this is work that I'm currently doing now, so this is, and I just wanted to show you what the measure looks like right now. So this is the diabetes distress scale. It's 17 items, you fill it out, and then it gets scored. But one of the things that I think will be really, really helpful and is to turn this into an interview. So the group that made this scale, we've been in touch with them. We being the diabetes center, there's a diabetes center called Steno Diabetes Center in Copenhagen, Denmark. And I've got some collaboration with them, and we're going to turn this scale into an interview so that it can allow us to have a conversation between individuals with diabetes and healthcare providers about distress. And how that interview would look would really be to take some of those items and take them apart. So again, when we talk about diabetes distress, let's then start to think about 4 aspects of that. To what extent are you feeling emotional burden? To what extent do the tasks of diabetes self-management distress you? Do you have distress stemming from the relationship between yourself and the provider, or between you and other people in your world? And so we're going to now take those apart. And here are the items of the diabetes distress scale, but these are wonderful questions that can be in a dialogue between an individual with diabetes and a healthcare provider. So do you feel that diabetes is taking up too much of your mental, physical energy every day? Do you feel angry, scared, and or depressed when you think about living with diabetes? Do you feel it controls your life? Do you feel you'll end up with complications no matter what you do? And overall, do you feel overwhelmed by the demands of diabetes? So these are questions that can be part of a dialogue. And just think about the individual who would start to say yes, 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 yes. There's somebody who's going to be clearly distressed. But importantly, that type of distress is very much about their diabetes and therefore needs to be supported in the context of diabetes management. We can do exactly the same thing with regard to what we call regimen distress. Do you feel that you're not testing your blood sugars frequently enough? Do you feel that you're failing with your diabetes regimen? Notice that in both of those two scale slides, this slide and the slide before, there's one item that's in large font, and I'll describe that in a minute. And feeling I'm failing, not feeling confident in my day-to-day ability, feeling I'm not sticking closely enough to a good meal plan, or not feeling motivated. So we can ask questions, and those answers can be very helpful guides. Patient-provider distress, feeling a healthcare provider doesn't know enough about diabetes and diabetes care. And remember that the majority of people living with diabetes in Canada are not treated inside diabetes centers but by primary care providers, and so they may not be experts in diabetes. Feeling that my healthcare provider doesn't give me clear enough directions on how to manage diabetes. And now think about being even inside a diabetes center, and sometimes you get different messages from different people, and that can be very confusing for the individual. Feeling that my healthcare provider doesn't take my concerns seriously, or that I don't have a healthcare provider who I can see regularly. So this really points towards us. So this I think is one of the most helpful. I love this part of that scale because it points the finger directly at us healthcare providers. Are we doing our job from a management perspective? And then the final scale is feeling that friends and family are not supportive enough of my self-care, feeling that friends or family don't appreciate how difficult living with diabetes can be, feeling that friends or family don't give me the emotional support I would like. So this is the diabetes distress interview. That will be the core of the interview that we'll create. But importantly, one of the things that we're going to do is we're going to minimize that to something even smaller. So this is, interestingly enough, I'm going to be training the diabetes education centers that work with me in Nova Scotia, in the Nova Scotia Health Authority Central Zone. On October 2nd, we actually have a training session where I'm going to train them in the use of this scale. And then we'll work with CDA to take that training and actually expand it to other healthcare providers across the country. But this is the way in which we could very briefly try to identify how distressed you are. And the questions we could ask you would be as follows. We could say, we're interested in understanding your experience of diabetes in the past month. Using a rating card, I'll show you that on the next slide, pick a number that best reflects how much of a problem the following have been. And here's where you see those two items that I had in large font before. In the past month, have you been feeling overwhelmed by the demands of living with diabetes? And in the past month, have you feeling that you're failing with your diabetes regimen? Turns out those two items are strongly predictive of overall distress. And I made available an article on this website that you can access that describes those studies. And the response scale would be you'd get someone to give you an answer between 1 and 6, where 1 would be no problem, 3 to 4 would be a moderate, and 6 would be a serious problem. And when this is scored, the average, so if between the average score, between those two ratings, ends up being 2 or more, that's an indication of diabetes distress. So it doesn't take a lot to raise issues. So this can be helpful, and really when we think about burden, I think for me it's a no-brainer, and I just wanted to show you this. This is a question that I've been asking people for decades in diabetes, and I ask it as follows. If diabetes were a weight that you carried around in a knapsack on your back, how heavy would it be? Would it be a 1-pound loaf of bread, a 5-pound sack of potatoes, a 50-pound iron anvil, or a 2-ton truck? I love that question personally because I find that people get it, and it really quickly helps us address burden. Also, why is diabetes distressing? And it's like, wow, Why not? Diabetes can be overwhelming. There's so many different things that you have to pay attention to. It's complex because it's managing it is really involves all these factors that interact. It's constant. Most of us, even if we're interested in taking care of ourselves, like our weekends and our summer vacations and our retirement packages, it can be unforgiving. You can develop complications no matter what you do, and it can be plagued by uncertainty. So each of these characteristics, overwhelmed, complex, constant, unforgiving, uncertain, that is distressing. And so it's really no wonder that there is distress around diabetes. So now that I know it, what do I do with it? And so what I would say is that, two things I'd like you to become aware of is, first is that when people have emotions, they're not always bad. So I'm trying to send a very clear message to my colleagues who are physicians and other healthcare providers that just because a person is upset, don't think that's a bad thing. Because we psychologists categorize emotions into 3 categories: primary emotions, secondary emotions, and interpersonal emotions. And only the secondary emotions or the interpersonal emotions might be problematic. Primary emotions are good. They're natural, appropriate emotional responses to lived experience. So if you have a loss, you're going to feel sad. If you have a threat, you're going to feel anxious. If you feel invaded, you're going to feel angry. And so the emotions may be appropriate to the situation. And what's really, really important about that is you don't need medication for that. What you need is the ability to listen, to express yourself, to be heard, and what we call to sit with. And the best example of that would be grief. We all know that if a person is experiencing grief, what you do is provide them the opportunity to feel their emotions in a supportive way so that they can work it through. So that's, I think, a very positive message, and one of the reasons why we think that diabetes distress can be managed inside diabetes centers. And so what do I ask the diabetes provider to take on? I would say that, well, it's not your job to change the patient, to change the individual with diabetes, but what healthcare providers can do is identify the issue, educate the individual, make recommendations, and provide support for the individual pursuing solutions to those problems. It's also critically important that we understand that a lot of advice around helping people find out the value in what they're doing so they can, what we call, replace the function. So if we were live, I could ask people for a show of hands for people who consider themselves to be emotional eaters. And I would say 1/3 to 1/2 of us would put up our hands. And so what does it mean to be an emotional eater? What it means is that food is a coping response. So food serves a purpose. So how can you eat healthier if food, unhealthy food, is a coping response? You need a new coping response. You need to replace the function that food serves. And so healthcare providers can be extremely helpful in helping people find alternatives. And then importantly, when we're talking about managing and being sensitive to emotional issues in diabetes, what I ask my colleagues to do is keep the conversation going and pay attention to 4 things, what I've come to call the 4 S's. And those are self-image. Is the person able to live with diabetes, to bring diabetes into their life so that they've adapted to it, they've accepted it, they feel proud of themselves for their ability to manage their diabetes? Are they able to develop confidence, what we call self-efficacy, their confidence in their ability to manage diabetes? Do they have appropriate social support when they leave the clinic to manage that? And how does stress affect them? And have they got stress management strategies that can be helpful for them to keep their eye on the ball with regard to glucose management? All right, so that sort of wraps up the formal presentation of this. So I'd like to thank you for your attention, and now I will turn over back to Farah because we can have some time for questions.
Great. Thank you so much, Dr. Valles. Really great presentation. You've shared with us a lot of great insight on diabetes distress. And from all the folks in the Q&A section, they've said thank you very much for the webinar. So we know that everyone that's participated has had a really great experience. So folks, we're going to take some time, a few minutes now for questions. And we will respect your time and wrap up at the end of the hour. So I'll start with one of our first questions. Our first participant is asking, is there a study regarding distress for type 2 diabetics and co-occurring diseases such as sleep apnea, which causes overeating and poor sugar control?
Right, thank you. So that's a really good question. And I think what we so the answer to that question, I think, would be best said as follows: that healthcare providers work with Lego blocks. So just those child's toy of Lego blocks, where you get these little blocks and you build things together. And so what I mean by that would be that we certainly know certain things, and then what we have to do is sort of what we know about A and what we know about B, and then we kind of have to put it together. So, at this point in time, diabetes distress is a relatively new concept. So there aren't studies that are saying, okay, let's talk about what would be called comorbidity. So what about diabetes distress in the context of somebody with diabetes and something else like sleep apnea? But what we do know is that when people have more than one medical problem, then two comments to that. One is the burden is not an addition math problem. So it's not 1 + 1 = 2. It's a multiplication equation. So 1 + 1 = 8. So I think that it's important for us to understand that people can cope with manageable levels of things. But when you start talking about multiple problems, and an example that I see in my practice all the time would be when somebody has diabetes and also they have a GI condition, Crohn's disease or celiac disease. And so they've got two diseases, and what I can tell you about those two diseases is that the diets that are recommended for each disease are opposite to each other. So it can be a nightmare from a distress point of view. But the other point that you're talking about, I think that's really interesting in this question, is the impact of something like sleep apnea, or let's look at sleep disorders in general, and eating, and what those kind of relationships are. And you're right, and that's why the burden would go up in that individual, because the sleep apnea, sleep disturbance, increases appetite, increases overeating, and that then leads to sugar control. So you actually would have increased distress, but also from a behavioral point of view, increased activities that we would want to put on the agenda for that individual.
Great. Thank you so much for that response. We've actually had a few people ask some similar questions. They're actually looking for where they can obtain the diabetes distress scale, and if that is something that they can either find online or if we can direct them to that.
Yes, absolutely. So, so you should know the answer to this. I sent that scale. Remember that paper I sent that I thought people could access?
Yes, I was going to speak to that in a moment. So
okay,
folks,
so
I'll just jump in.
That has, yeah.
Yeah, I'll just jump in for one quick second. So actually, to the bottom of your screen, you'll see something that's called the resource list. And in there, Dr. Valles has provided all of you with an article. And now I'll let him, I guess, explain the article.
So the article would describe to you both the general 17-item distress scale and also the 2-item version. So I picked that article thinking that it would be the simplest way of accessing information about the diabetes distress scale. And so if you're interested, I would access that article directly. It will kind of provide you the background that I was talking about And my intent in this conversation is really to try to encourage both individuals with diabetes to become more informed about diabetes distress and healthcare providers to become more comfortable in those conversations. If you wanted to access the original paper, which is where you'll find that original distress scale, it's in the references to that paper. Or the other thing would be you could always just contact me and I'd be more than happy to send that original paper to you.
Great. Thanks for that. We'll move on to our next question. But before we do, folks, I just wanted to remind you, we have quite a few questions coming in right now. So I do apologize if we don't get all of them answered. But please follow up with us if we do not get to your question. Send us an email at webinars@diabetes.ca, and we'll be sure to follow up with you on an individual basis. So with that being said, we'll get to our next question. Another participant has asked, it is surprising that more type 2 diabetics experience depression than type 1 diabetics, because I thought type 1 diabetics is a more serious form of diabetes. Can you shed some light on this, please?
Yeah, that's a great question. Thanks for that one. I like that. That's an interesting question. And so that's actually quite an interesting example. So first thing I would say to you is that that we classify type 1 and type 2 diabetes together as diabetes. And diabetes is a serious disease regardless of what type you have. So the difference in the disease would be the mechanism by which glucose control gets disturbed. Type 1 diabetes, it's disturbed because the beta cells in the pancreas are killed off and there is no insulin. So without external insulin, you will not survive. And prior to the discovery of insulin, the diabetes was fatal. And so that does sound very, very serious. But what that though means is that the person who has type 1 diabetes, who has adapted well to the disease, in fact, it's like second nature to them, and their control might be actually quite good because they've just incorporated that work into it. And so the emotional burden could actually be less in type 1 because they've done that acceptance work. Someone in type 2 goes along and says, well, hang on a second, geez, I feel okay, and you're telling me I've got diabetes. Well, that's not okay. And so the distress element actually might go up. So the seriousness is not so much based on type. It's really based on the extent to which the individual is able to manage their disease. So it's those self-care behaviors that lead to various levels of glucose control. So a person who's in really good control with type 1, in essence, maybe in a less serious of a condition than somebody who has type 2 diabetes, who basically has been, pretty much putting it in the back burner, not really taking very much care of themselves, and sort of going around with high levels of glucose in their system for a long period of time. That person might actually be more serious. So it's a great question. And I think it often reflects the fact that type 1s have, I guess I don't know, I don't want to offend anybody, but there's a bit more of a dramatic experience with type 1 diabetes. But what's interesting about that, from a psychology point of view, is the dramatic impact of diabetes sometimes means that people adapt to it very quickly. And I love to make the following statement. Children who have type 1 diabetes often become amazing adults. That is, they not only do they develop normally, but they actually can develop to be better than normal. And the reason for that is because they've had to deal with the hardships, the uncertainties, the difficult work. And so it actually gives them opportunity to develop coping skills that the healthy child actually doesn't have to access. So it's an interesting issue, really. Thank you for that.
Great. So we'll just take one more question here because we are down to the hour, and I do want to respect everyone's time on the line. We have a few people asking, any tips on helping healthcare professionals, including pharmacists, on how to deal with patients that are distressed?
Absolutely. I think one of the things that would be, so that's why I ended the presentation with the notion of primary emotions. And what I would like to say to healthcare providers, and pharmacists are an excellent example of a healthcare provider who can be very helpful for people with diabetes. And there's two reasons that make pharmacists and pharmacies, I think, really important diabetes team members. Reason number one, people come to see you when they choose. So people are they're less defensive when they come to see you because they're not responding to somebody else's appointment. They're coming when it's convenient to them. So they kind of arrive in a bit more of an open-minded. And the second is that they really trust pharmacists to give them the straight goods. That is, sometimes people feel like we healthcare providers are just so pro, you've got to do this, you've got to do this. And of course, we're going to tell you that, you've got to take care of yourself. Whereas in the pharmacy, the role of the pharmacist is really just to more present the information. So I think the pharmacy is a good context. And then what happens then is that think about it, and if you think about a healthcare provider who is not trained in mental health services, that they are not qualified to work with the challenging emotions. So when it gets into secondary emotions, clinical depressions, stuff that might respond to cognitive therapies, stuff that requires maybe more social support or health coaching, then you would know that. But you will know that because if you start by thinking about it, okay, what am I going to do? I'm going to identify it. So then I can start to say, well, could we talk a little bit about what's stressing you? Could I ask you to maybe help me figure out whether is it the experience of having diabetes, just that sort of burden? Is it the tasks of diabetes? Is it navigating the system with people like myself or others? Or is it what happens in your world? And so you then start to help the person make sense of their experience, and then you give them the opportunity to talk a bit about it. And then what you will see are people who will say, thank you, this has been really helpful. And then you'll see, because remember, people are not only composed of various levels of distress, but also of various levels of well-being. And so when we start to allow people to talk about their experiences, they feel heard, they feel understood, and surprise, surprise, they then start to say, you know what, I think I could do this. I've tackled other difficult things in my life. Thanks, this was really helpful. And then my final statement would be, if that doesn't work, you will know it doesn't work. And when you discover it doesn't work, that's when you start thinking about, okay, where are the psychologists? Where are the resources? And I formed a group last year with a number of other psychologists across the country. So there's about 6 of us that span the country, and we call ourselves Can Change. And we're trying to provide more systematic resources for psychological issues for diabetes and other chronic diseases. So I hope that sort of addressed that question around healthcare providers in the context of the pharmacy.
Great. Thank you so much, Dr. Valles, for that response. So again, folks, I do see there's still a few questions we haven't gotten to. Unfortunately, this does conclude our webinar for today, but I do hope you email us at webinars@diabetes.ca, and we'll be sure to follow up with the responses. I do want to send a quick thank you out to everyone who attended our webinar today. I do hope that some people are, back from the afternoon session. We did have a few technical difficulties, so there was smooth sailing this evening, and I'm really happy to see some of the familiar names that have participated. So I'm happy that you guys have come back. I do want to say thank you to our volunteers who helped coordinate this session, as well as our sponsors, Bayer and Merck. Without them, all of these great educational webinars wouldn't be possible. We do have some upcoming webinars as well, so I do hope all of you guys will come back and join us. So you can take a look at the next 3 that are coming up over the next 3 weeks. So please visit our website and register for those. The Diabetes Association has quite a few programs and services that we offer. To learn more about the Diabetes Charter, an expo coming up in your community, or to participate in our virtual health coaching program, please call us at 1-800-BANTING or visit our website at diabetes.ca. So once again, I want to thank everyone, and I hope you have a lovely evening. And if, again, for any questions, please email us at webinars@diabetes.ca. Thanks so much.